everyone. This is your Nandini ma'am. Today we are going to start reading of chapter number 3, Pectoral Region of Human Anatomy, Volume 1. Let's get started. Introduction. The pectoral region lies on the front of the chest. It essentially consists of structures which connect the upper limb to the anterior lateral chest wall. Breast lies in this region. Surface landmarks. The following features of the pectoral region can be seen or felt on the surface of body. Number 1. The clavicle lies horizontally at the root of the neck, separating it from the front of the chest. The bone is subcutaneous and therefore palpable throughout its length. Medially, it articulates with the sternum at the sternoclavicular joint and laterally with the acromion process at the acromioclavicular joint. Both the joints are palpable because of the upward projecting ends of the clavicle, figure 3.1. The sternoclavicular joint may be masked by the sternocleidomastoid muscle. Number 2. The jugular notch, interclavicular or suprasternal notch, lies between the medial ends of the clavicles at the superior border of the manubrium sterni. Number 3. The sternal angle. Angle of Lewis is felt as a transverse ridge about 5 cm below the jugular notch, figure 3.1. It marks the manubrio-sternal joint laterally on either side. The second costal cartilage joins the sternum at its level. The sternal angle thus serves as a landmark for identification of the second rib. Other ribs can be identified by counting downwards from the second rib. Number 4. The epigastric fossa, pit of the stomach, is the depression in the infrasternal angle. The fossa overlies the xiphoid process and is bounded on each side by the seventh costal cartilage. Number 5. The nipple is markedly variable in position in females. In males and in immature females, it usually lies in the fourth intercostal space, just medial to the mid-clavicular line or 10 cm from the mid-sternal line. In fact, the position of the nipple is variable even in males. Number 6. The mid-clavicular line passes vertically through the middle of clavicle, the tip of the ninth costal cartilage, and mid-inguinal point. Number 7. The infraclavicular fossa, deltopectoral triangle, is a triangular depression below the junction of the lateral and middle thirds of the clavicle. It is bounded medially by the pectoralis major, laterally by the anterior fibers of the deltoid, and superiorly by the clavicle. The tip of the coracoid process of the scapula lies 2 to 3 cm below the clavicle, overlapped by the anterior fibers of the deltoid. It can be felt on deep palpation just lateral to the infraclavicular fossa. Number 9. The acromion process of the scapula is a flattened piece of bone that lies subcutaneously forming the top of the shoulder. The posterior end of its lateral border is called the acromial angle, where it is continuous with the lower lip of the crest of the spine of the scapula. The anterior end of its medial border articulates with the clavicle at the acromioclavicular joint. Number 10. The deltoid is triangular muscle with its apex directed downwards. It forms the rounded contour of the shoulder, extending vertically from the acromion process to the deltoid tuberosity of the humerus. Number 11. The axilla is a pyramidal space between the arm and chest. When the arm is raised, abducted, the floor of the axilla rises, the anterior and posterior folds stand out, and the space becomes more prominent. The anterior axillary fold contains the lower border of the pectoralis major, and posterior axillary fold contains the tendon of the latissimus dorsi winding around the fleshy teres major. The medial wall of the axilla is formed by the upper four ribs covered by the serratus anterior. The narrow lateral wall presents the upper part of the humerus covered by the short head of the biceps and the coracobrachialis. Axillary arterial pulsations can be felt by pressing the artery against the humerus. The cords of the brachial plexus can also be rolled against the humerus. The head of the humerus can be felt by pressing the fingers upwards into the axilla. Number 12. The mid-axillary line is a vertical line drawn midway between the anterior and posterior axillary folds. Dissection. Mark the following points. Center of the suprasternal notch, xiphoid process, 7 o'clock position at the margin of areola, and 5 o'clock position at the margin of areola right side. Lateral end of clavicle, figure 3.2. Given an incision vertically down from the first point to the second, which joins the center of the suprasternal notch to the xiphoid process in the mid-sagittal plane. From the lower end of this line, extend the incision upward and laterally till you reach to the third point on the areolar margin. Encircle the areola and carry the incision upwards and laterally till the anterior axillary fold is reached. Continue the line of incision downwards along the medial border of the upper arm till its junction of upper one-third and lower two-thirds. Extend this incision transversely across the arm. Make another incision horizontally from the xiphoid process across the chest wall till the posterior axillary fold. Lastly, give horizontal incision from the center of suprasternal notch to the lateral end of the clavicle. Reflect the two flaps of skin towards the upper lip. Superficial fascia. The superficial fascia of the pectoral region is visualized after the skin has been incised. It contains moderate amount of fat and is continuous with that of surrounding regions. The breast, which is well developed in females, is the most important of all contents of this fascia. The fibrous septa given off by the fascia support the lobes of the gland and the skin covering the gland. Contents. In addition to fat, the superficial fascia of the pectoral region contains the following. Number 1. Cutaneous nerves derived from the cervical plexus and from the intercostal nerves. Number 2. Cutaneous branches from the internal thoracic and posterior intercostal arteries. Number 3. The platysma. Number 4. The breast. Cutaneous nerves of the pectoral region. The cutaneous nerves of the pectoral region are as follows. Figure 3.3 and 3.4. Number 1. The medial, intermediate, and lateral supraclavicular nerves are branches of the cervical plexus C3, C4. They supply the skin over the upper half of the deltoid and from the clavicle down to the second rib. Number 2. The anterior and lateral cutaneous branches of the second to sixth intercostal nerves supply the skin below the level of the second rib. The intercostobrachial nerve of T2 supplies the skin of the floor of the axilla and the upper half of the medial side of the arm, figure 3.3. It is of interest to note that the area supplied by spinal nerve C3 and C4 directly meets the area supplied by spinal nerves T2 and T3. This is because of the fact that the intervening nerves C5 to C8 and T1 have been pulled away to supply the upper limb. It may also be noted that normally the areas supplied by adjoining spinal nerves overlap, but because of what has been said above, there is hardly any overlap between the area supplied by C3 and C4 above and T2 and T3 below, figure 3.4. Cutaneous vessels. The cutaneous vessels are very small. The anterior cutaneous nerves are accompanied by the perforating branches of the internal thoracic artery. The second, third, and fourth of these branches are large in females for supplying the breast. The lateral cutaneous nerves are accompanied by the lateral cutaneous branches of the posterior intercostal arteries. Figure 3.8. Platysma. The platysma is a thin, broad sheet of subcutaneous muscle. The fibers of the muscle arise from the deep fascia covering the pectoralis major, run upwards and medially, crossing the clavicle and the side of the neck, and are inserted into the base of the mandible and into skin over the posterior and lower part of the face. The platysma is supplied by a branch of the facial nerve. When the angle of the mouth is pulled down, the muscle contracts and wrinkles the skin of the neck. The platysma may protect the external jugular vein, which underlies the muscle, from external pressure. Breast. The breast is the most important structure present in the pectoral region. The breast is found in both sexes but is rudimentary in the female. In the male, it is well developed in the female after puberty. It forms an important accessory organ of the female reproductive system and provides nourishment to the newborn in the form of milk. Its shape may be hemispherical, conical, piriform, pendulous, or flat situation. The breast lies in the superficial fascia of the pectoral region. It is divided into four quadrants, that is, upper medial, upper lateral, lower medial, and lower lateral. A small extension of the upper lateral quadrant, called the axillary tail of Spence, passes through an opening in the deep fascia and lies in the axilla. The opening is called foramen of Langer. Its base is circular. Extent of the base. Vertically, it extends from the second to the sixth ribs. Horizontally, it extends from the lateral border of the sternum to the mid-axillary line. Deep relations. The deep surface of the breast is related to the following structures in that order. Figure 3.6. The breast lies on the deep fascia, which is pectoral fascia covering the pectoralis major. Still deeper, there are parts of three muscles, namely the pectoralis major, the serratus anterior, and the external oblique muscle of the abdomen. Number 3. The breast is separated from the pectoral fascia by loose areolar tissue called the retromammary space. Because of the presence of this loose tissue, the normal breast can be moved freely over the pectoralis major. Structure of the breast. The structure of the breast may be conveniently studied by dividing it into the skin, the parenchyma, and the stroma. The parenchyma is known as the mammary gland. Skin. It covers the gland and presents the following features. Number 1. A conical projection, called the nipple, is present just below the center of the breast at the level of the fourth intercostal space, 10 cm from the midline. The nipple is porosed by 15 to 20 lactiferous ducts. It contains circular and longitudinal smooth muscle fibers, which can make the nipple stiff or flatten it, respectively. It has a few modified sweat and sebaceous glands. It is rich in nerve supply and has many sensory end organs at the termination of nerve fibers. Number 2. The skin surrounding the base of the nipple is pigmented and forms a circular area called the areola. This region is rich in modified sebaceous glands, particularly at its outer margin. These becomes enlarged during pregnancy and lactation to form raised tubercles of Montgomery. Oily secretions of these glands lubricate the nipple and areola and prevent them from cracking during lactation. Apart from sebaceous glands, the areola also contains some sweat glands and accessory mammary glands. The skin of the areola and nipple is devoid of hair and there is no fat subjacent to it. Below the areola lie lactiferous sinus where stored milk is seen. Parenchyma mammary gland. Mammary gland is a compound tubulo-alveolar gland which secretes milk. As it lies in superficial fascia, there is no capsule. Mammary gland is a modified sweat gland. The gland consists of 15 to 20 lobes. Each lobe is a cluster of alveoli and is drained by a lactiferous duct. The lactiferous ducts converge towards the nipple and open on it. Near its termination, each duct has a dilatation called a lactiferous sinus. Figures 3.7a and b. Stroma. It forms the supporting framework of the gland. It is partly fibrous and partly fatty. The fibrous stroma forms septa, known as the suspensory ligaments of Cooper, which anchor the skin and gland to the pectoral fascia. Figure 3.7a. The fatty stroma forms the main bulk of the gland. It is distributed all over the breast except beneath the areola and nipple. Blood supply. The mammary gland is extremely vascular. It is supplied by the branches of the following arteries. Figure 3.8. Internal thoracic artery, a branch of the subclavian artery through its perforating branches. The lateral thoracic, upper thoracic, superior thoracic, and acromiothoracic branches of the axillary artery. Lateral branches of the posterior intercostal arteries. The arteries converge on the breast and are distributed from the anterior surface. The posterior surface is relatively avascular. The veins follow the arteries. They first converge towards the base of the nipple, where they form an anastomotic venous circle from where veins run in superficial and deep sets. The superficial veins drain into the internal thoracic vein and into the superficial veins of the lower part of the neck. The deep veins drain into the axillary and posterior intercostal veins. Nerve supply. The breast is supplied by the anterior and lateral cutaneous branches of the fourth to sixth intercostal nerves. The nerves convey sensory fibers to the skin and autonomic fibers to smooth muscle and to blood vessels. The nerves do not control the secretion of milk. Secretion is controlled by the hormone prolactin secreted by the pars anterior of the hypophysis cerebri. The diagnosis and management of breast disease should be done carefully. Lymphatic drainage. Lymphatic drainage of the breast assumes great importance to the surgeon because carcinoma of the breast spreads mostly along lymphatics to the regional lymph nodes. The subject can be described under two headings: the lymph nodes and the lymphatic vessels. Lymph nodes. Groups of lymph nodes are shown in figure 3.9. Lymph from the breast drains into the following lymph nodes, figure 3.9. Number 1. The axillary lymph nodes, chiefly the anterior group. The posterior, lateral, central, and apical groups of nodes also receive lymph from the breast either directly or indirectly. Number 2. The anterior thoracic nodes, which lie along the internal mammary vessels. Figure 3.10. Number 3. Some lymph from the breast also reaches the supraclavicular nodes, the cephalic node, the posterior intercostal nodes, the subdiaphragmatic and subperitoneal lymph plexus. Lymphatic vessels. The superficial lymphatics drain the skin over the breast except for the nipple and areola. The lymphatics pass radially to the surrounding lymph nodes. The deep lymphatics drain the parenchyma of the breast. They also drain the nipple and areola, figure 3.11. Some further points of interest about the lymphatic drainage are as follows. Number 1. About 75% of the lymph from the breast drains into the axillary nodes, 20% into the anterior thoracic nodes, and 5% into the posterior intercostal nodes. Among the axillary nodes, the lymphatics end mostly in the anterior group and partly in the posterior and apical groups. Lymph from the anterior and posterior groups passes to the central and lateral groups and through them to the apical group. Finally, it reaches the supraclavicular nodes. The anterior thoracic nodes drain the lymph not only from the inner half of the breast but also from the outer half as well. Number 3. A plexus of lymph vessels is present deep to the areola. This is the subareolar plexus of Sappe, figure 3.11. Subareolar plexus and most of lymph from the gland drain into the anterior or pectoral group of lymph nodes. Number 4. The lymphatics from the deep surface of the gland pass through the pectoralis major muscle and clavipectoral fascia to reach the apical nodes and also to the anterior thoracic nodes. Figure 3.12. Number 5. Lymphatics from the lower and inner quadrants of the breast may communicate with the subdiaphragmatic and subperitoneal lymph plexus after crossing the costal margin and then piercing the anterior abdominal wall through the upper part of the linea alba. Number 6. Anterior and central groups of nodes are commonly involved in carcinoma breast. Development of the breast. The breast develops from an ectodermal thickening called the mammary ridge, milk line, or line of Scholes. Figure 3.13. This ridge extends from the axilla to the groin. It appears during the 4th week of intrauterine life, but in human beings, it disappears over most of its extent, persisting only in the pectoral region. The gland is ectodermal and the stroma mesodermal in origin. Number 2. The persisting part of the mammary ridge is converted into a mammary pit. Secondary buds grow down from the floor of the pit. These buds divide and subdivide to form the lobes of the gland. The entire system is first solid and is later canalized. At birth or later, the nipple is everted at the site of the original pit. Number 3. Growth of the mammary glands at puberty is caused by estrogens. Apart from estrogens, development of secretory alveoli is stimulated by progesterone and by the prolactin hormone of the hypophysis cerebri. Number 4. Developmental anomalies of the breast are amastia, absence of the breast; athelia, absence of nipple; polymestia, supernumerary breasts; polythelia, supernumerary nipples; gynecomastia, development of breasts in a male, which occurs in Klinefelter's syndrome. Histology of breast. The mammary glands are specialized accessory glands of the skin, which have evolved in mammals to provide nourishment to the young ones. Mammary gland consists of 15 to 20 lobes with the same number of ducts. Each lobe is made up of many lobules containing echini. Histologically, only lobules are discernible in the gland. Resting phase in non-pregnant adult female. The mammary gland in this phase consists mainly of ducts and their branches. Figure 3.14. The stroma has connective tissue and fat cells. The intralobular ducts are usually lined by low columnar epithelium resting on a basement membrane. The intralobular connective tissue, which is derived from the papillary layer of the dermis, is more cellular, containing fibroblasts. The interlobular connective tissue, which lies between the ducts of adjacent lobule, is derived from the reticular layer of the dermis and is more fibroreticular in nature. It contains fat lobules. Lactating phase. The gland is full of echini with minimum amount of connective tissue. Some echini are lined by tall columnar cells, others by normal columnar cells. The nucleus may be round or oval and is seen in the middle of the cell. Figure 3.15. Droplets of fat accumulate near the free surface of the cell. Myoepithelial cells may be seen between the basement membrane and the secretory cells. Ducts are also seen, but they are fewer in number as compared to the echini. The bigger ducts are lined by stratified columnar or columnar epithelium. Clinical anatomy. The upper and outer quadrant of breast is a frequent site of carcinoma. The first lymph node draining the tumor-bearing area is called sentinel node. Abscesses may also form in the breast and may require drainage. The following facts are worthy of note. Incisions of breast are usually made radially to avoid cutting the lactiferous ducts. Figure 3.9. Cancer cells may infiltrate the suspensory ligaments. The breast then becomes fixed. Contraction of the ligaments can cause retraction or puckering of the skin. Infiltration of lactiferous ducts and their consequent fibrosis can cause retraction of the nipple. Obstruction of superficial lymph vessels by cancer cells may produce edema of the skin, giving rise to an appearance like that of the skin of an orange. Figure 3.16. Because of communications of the superficial lymphatics of the breast across the midline, cancer may spread from one breast to the other. Figure 3.17. Because of communications of the lymph vessels with those in the abdomen, cancer of the breast may spread to the liver and cancer cells may drop into the pelvis, producing secondaries there. Figure 3.17. Apart from the lymphatics, cancer may spread through the segmental veins. In this connection, it is important to know that the veins draining the breast communicate with the vertebral venous plexus of veins. Through these communications, cancer can spread to the vertebrae and to the brain. Figure 3.18. Carcinoma usually arises from epithelium of large ducts. Self-examination of breasts. Inspect symmetry of breasts and nipples, change in color of skin. Retraction of nipple is a sign of cancer. Discharge from nipple on squeezing it. Palpate all four quadrants with the palm of hand. Note any palpable lump. Raise the arm to feel lymph nodes in axilla. Mammogram may reveal cancerous mass. Figure 3.19. Fine needle aspiration cytology is safe and quick method of diagnosis of lesion of breast. Retracted nipple is a sign of tumor in the breast. Size of mammary gland can be increased by putting an implant inside the gland. The size can be reduced by breast reduction surgery. Cancer of the mammary glands is the most common cancer in females of all ages. It is more frequently seen in postmenopausal females due to lack of estrogen hormones. Self-examination of the mammary gland is the only way for early diagnosis and appropriate treatment. Mastectomy is the medical term for the surgical removal of one or both breasts partially or completely. A mastectomy is usually carried out to treat breast cancer. Lumpectomy is the removal of only the tumor. Radical mastectomy is a surgical procedure involving the removal of breast, underlying pectoral muscles, and lymph nodes of the axilla as a treatment for advanced breast cancer. Deep fascia. The deep fascia covering the pectoralis major muscle is called the pectoral fascia. It is thin and closely attached to the muscle by numerous septa passing between the fasciculi of the muscle. It is attached superiorly to the clavicle and anteriorly to the sternum. Superior-laterally, it passes over the infraclavicular fossa and dectopectoral groove to become continuous with the fascia covering the deltoid. Inferior-laterally, the fascia curves round the inferior lateral border of the pectoralis major to become continuous with the axillary fascia. Inferiorly, it is continuous with the fascia over the thorax and the rectus sheath. Muscles of the pectoral region. Introduction. Muscles of the pectoral region are described in tables 3.1 and 3.2. Study them on the articulated skeleton. Some additional features are given below. Pectoralis major. Structures under cover of pectoralis major. Bones and cartilages. Sternum, costal cartilages and ribs. Fascia, clavipectoral. Muscles, subclavius, pectoralis minor, serratus anterior, intercostals, and upper parts of the biceps brachii and coracobrachialis. Vessels, axillary. Nerves, cords of brachial plexus with their branches. Okay. Table 3.1, muscles of the pectoral region. Muscle, origin, insertion. Pectoralis major, figure 3.20. Anterior surface of medial 2/3 of clavicle, half the breadth of anterior surface of manubrium and sternum up to the 6th costal cartilage. 2nd to 6th costal cartilages, sternal end of 6th rib, aponeurosis of the external oblique muscle of abdomen. It is inserted by a bilamellar tendon on the lateral lip of the bicipital groove in form of U. The two laminae are continuous with each other inferiorly. The anterior lamina is thicker and shorter than the thinner and longer posterior lamina. The anterior lamina receives superficial, clavicular, and deep manubrial fibers. Posterior lamina gets costal, sternal, and aponeurotic fibers. Pectoralis minor, figure 3.21. 3, 4, 5 ribs near the costochondral junction, intervening fascia covering external intercostal muscles, medial border and upper surface of the coracoid process. Subclavius, figure 3.21. Origin, first rib at the costochondral junction. Insertion, subclavian groove in the middle 1/3 of the clavicle. Figure 3.2, nerve supply and actions of muscles. Muscle, pectoralis major, figure 3.20, nerve supply. Medial and lateral pectoral nerves. Medial pectoral reaches it after pursing pectoralis minor. The lateral pectoral reaches the muscle by pursing clavipectoral fascia. Actions. Acting as a whole, the muscle causes abduction, adduction, and medial rotation of the shoulder joint. Clavicular part produces flexion of the arm. Sternocostal part is used in extension of flexed arm against resistance. The action of the muscle is adduction, not abduction. Pectoralis minor, figure 3.21. Medial and lateral pectoral nerves. Actions. Draws the scapula forward with serratus anterior. Depresses the point of the shoulder. Subclavius. Nerve to subclavius from upper trunk of the brachial plexus. Actions. Steadies the clavicle during movements of the shoulder joint. Forms a cushion for axillary vessels and divisions of trunks of brachial plexus. Bilaminar tendon of pectoralis major. The muscle is inserted by a bilaminar tendon into the lateral lip of the intertubercular sulcus of the humerus. The anterior lamina is thicker and shorter than the posterior. It receives two strata of muscle fibers, superficial fibers arising from the clavicle and deep fibers arising from the manubrium, figure 3.20. The posterior lamina is thinner and longer than the anterior lamina. It is formed by fibers from the front of the sternum, second to sixth costal cartilages, sternal end of sixth rib, and from the aponeurosis of the external oblique muscle of the abdomen. Out of these, only the fibers from the sternum and aponeurosis are twisted around the lower border of the rest of the muscle. The twisted fibers from the anterior axillary fold. These fibers pass upwards and laterally to get inserted successively high into the posterior lamina of the tendon. Fibers arising lowest find an opportunity to get inserted highest and form a crescentic fold which fuses with the capsule of the shoulder joint. Clinical testing. Number 1, the clavicular head is made prominent by flexing the arm to a right angle. The sternocostal head can be tested by extending the flexed arm against resistance. Number 2, sternocostal head is made prominent by abducting arm to 60 degree and then touching the opposite hip. Number 3, pressing the fists against each other makes the whole muscle prominent. Figure 3.22b. Number 4, lifting a heavy rod makes clavicular part prominent. Depressing a heavy rod shows sternocostal part as prominent. Left arm, figure 3.22c. Clavipectoral fascia. Clavipectoral fascia is a fibrous sheath situated deep to the clavicular portion of the pectoralis major muscle. It extends from the clavicle above to the axillary fascia below. Figure 3.23. Its upper part splits to enclose the subclavius muscle. The posterior lamina is fused to the investing layer of the deep cervical fascia and to the axillary sheath. Inferiorly, the clavipectoral fascia splits to enclose the pectoralis minor muscle. See figure 4.3. Medially, it is attached to external intercostal muscle of upper intercostal spaces and laterally to coracoid process. Below this muscle, it continues as the suspensory ligament which is attached to the dome of the axillary fascia and helps to maintain it. The clavipectoral fascia is pierced by the following structures: lateral pectoral nerve, figures 3.12a and b, and cephalic vein. Thoracoacromial artery and lymphatics passing from the breast and pectoral region to the apical group of axillary lymph nodes. Serratus anterior. Serratus anterior muscle is not strictly muscle of the pectoral region, but it is convenient to consider it here. It is also called boxer's muscle or swimmer's muscle. Origin. Serratus anterior muscle arises by 8 digitations from the upper 8 ribs in the mid-axillary plane and from the fascia covering the intervening intercostal muscles. The first digitation appears in the posterior triangle of neck. It arises from the outer border of first rib and forms a rough impression on the second rib. Also, 5th to 8th digitations interdigitate with the costal origin of external oblique muscle of abdomen. Insertion. All 8 digitations pass backwards around the chest wall. The muscle is inserted into the costal surface of the scapula along its medial border. The first digitation is inserted from the superior angle to the root of the spine. The next 2 digitations are inserted lower down on the medial border. The lower 5 digitations are inserted into a large triangular area over the inferior angle. Figure 3.25. Nerve supply. The nerve supply to the serratus anterior is a branch of the brachial plexus. It arises from roots C5, C6, and C7 and is also called long thoracic nerve. The nerve enters through the apex of axilla behind first part of axillary artery to reach the medial wall of axilla. It lies on the surface of the muscle. Figures 3.22a and 3.24a. C5 root supplies first and second digitation. C6 root supplies third and fourth digitations. C7 root supplies 5th to 8th digitations. Actions. Along with the pectoralis minor, the muscle pulls the scapula forwards around the chest wall to protract the upper limb in pushing and punching movements. The fibers inserted into the inferior angle of the scapula pull it forwards and rotate the scapula so that the glenoid cavity is turned upwards. In this action, the serratus anterior is held by the trapezius, which pulls the acromion process upwards and backwards. The muscle steadies the scapula during weight carrying. It helps in forced inspiration. Additional features. Paralysis of the serratus anterior produces winging of scapula in which the inferior angle and the medial border of the scapula are unduly prominent. The patient is unable to do any pushing action, nor can he raise his arm above the head. Any attempt to do these movements makes the inferior angle of the scapula still more prominent. Clinical testing. Forward pressure with the hands against a wall or against resistance offered by the examiner makes the medial border and the inferior angle of the scapula prominent. If the serratus anterior is paralyzed. Dissection. Identify the extensive pectoralis major muscle in the pectoral region and the prominent deltoid muscle on the lateral aspect of the shoulder joint and upper arm. Demarcate the deltopectoral groove by removing the deep fascia. Now, identify the cephalic vein, a small artery, and a few lymph nodes in the groove. Clean the fascia over the pectoralis major muscle and look for its attachments. Divide the clavicular head of the muscle and reflect it laterally. Medial and lateral pectoral nerves will be seen supplying the muscle. Make a vertical incision 5 to 6 cm from the lateral border of sternum and reflect its sternocostal head laterally. Identify the pectoralis minor muscle under the central part of the pectoralis major. Note clavipectoral fascia extending between pectoralis minor muscle and the clavicular bone. Identify the structures piercing the clavipectoral fascia. These are cephalic vein, thoracoacromial artery, and lateral pectoral nerve. If some fine vessels are also seen, these are the lymphatic channels. Also, identify the serratus anterior muscle showing serrated digitations on the side of the chest wall. Facts to remember. Pectoralis major forms part of the bed for the mammary gland. 75% of lymph from mammary gland drains into axillary, 20% into anterior thoracic, and 5% into posterior intercostal lymph nodes. The sternocostal head of pectoralis major causes extension of the flexed arm against resistance. Pectoralis minor divides the axillary artery into 3 parts. Clinico-anatomical problem. A 45-year-old woman complained of a firm, painless mass in the upper lateral quadrant of her left breast. The nipple was also raised. Axillary lymph nodes were palpable and firm. It was diagnosed as cancer breast. Where does the lymph from the upper lateral quadrant drain? What causes the retraction of the nipple? Answer. The lymph from the upper lateral quadrant drains mainly into the pectoral group of axillary lymph nodes. The lymphatics also drain into supraclavicular and infraclavicular lymph nodes. Blockage of some lymph vessels by the cancer cells causes edema of skin with dimpled appearance. When cancer cells invade the suspensory ligaments, glandular tissue or the ducts, there is retraction of the nipple. So this was the chapter. Happy reading.